Welcome back to the deep dive. Today we are shifting gears quite a bit. Usually, we take this sort of leisurely stroll through a topic, exploring the nooks and crannies just for the sake of curiosity. But today is boot camp.
That's right. We are strapping on the armor today because we have a very specific mission. We're tackling the 2025 EAU guidelines on renal transplantation. And this is really specifically for you urologists out there.
Right, the fellows.
Exactly. The fellows, the trainees who are staring down the barrel of their board exams, your FEBU or your FRCS.
It's high-stakes territory. Because we know that when you're in that exam room or when you're facing a panel of examiners, you can't just know the general, vibe of the surgery.
No, absolutely not.
You need to know the law. You need to know exactly what those guidelines mandate, chapter and verse.
Precisely. And the EAU guidelines are structured in a way that is, well, it's very helpful for testing, but it's also very dangerous if you don't pay close attention. Because they distinguish very clearly between strong recommendations and weak recommendations.
So let's unpack that distinction right off the bat before we even dive into the medicine.
Right.
Because it sounds semantic, right? But for an exam candidate, it's life or death.
It really is. I mean, a strong recommendation means do this, period. It's based on high-quality evidence or a massive consensus that the benefits clearly outweigh the harms.
Right.
If you deviate from a strong recommendation in an exam, or frankly in court, you better have an incredibly specific, well-articulated reason, or you're going to fail that station.
Instantly. And the weak recommendations.
Those are more like, consider this. The evidence might be lower quality, or maybe the balance of benefit and harm is just closer. This is where clinical nuance lives.
Which examiners love to talk about.
Oh, they do. In an exam, discussing a weak recommendation shows you understand the complexity. It shows you can argue both sides. But missing a strong recommendation, that shows you're unsafe.
Unsafe. And that's a magic word you never want attached to your name in an exam. So our mission today is to highlight those strong recommendations, the red flags, if you will, and also to walk through the logic so it actually sticks in your memory.
Exactly.
We aren't just reading the text to you, we are hacking the memorization process. We've got the full 2025 text right here in front of us. It is dense. It's incredibly dense.
Very thick document.
But we've broken it down into a logical flow for you. We're going to go chronologically. The donor, preservation, the biopsy, the recipient's surgery, complications, and finally, the pharmacology heavy lifting.
It's a lot of ground to cover, but if we structure it right, it sticks.
Yeah.
We're going to try to simulate the pressure of the exam room a little bit here, too. I want you to imagine the examiners just, staring at you over their glasses.
So I'm sweating already just thinking about it. All right, let's start at the very beginning. Part 1. The donor. Specifically, retrieving the organ.
Right.
If I'm a surgeon setting up a living donor program, or if that examiner asks me what the absolute gold standard technique is, what am I saying?
You are saying endoscopic living donor nephrectomy. Specifically, laparoscopic.
Laparoscopic.
Yes. The guidelines are crystal clear on this. Established kidney transplant programs must prefer endoscopic approaches. That right there is a strong recommendation.
Okay, but let me play devil's advocate for a second. Why? Does the kidney actually work better? Is the graft survival higher? Because logically, you'd think, if I do an open surgery, I can be very gentle. I have my hands in there. I can handle the kidney less.
Right, that's what people think.
Doesn't that translate to better outcomes for the recipient?
And that is the classic exam trap. No, the kidney doesn't work better.
It doesn't.
No. The graft function and the graft survival rates are actually identical to open surgery. They're completely equivalent. The gold standard status comes entirely from the donor's perspective.
We're talking about the person who is walking away minus one organ.
Exactly.
Yeah.
We are operating on a healthy volunteer. This is a highly unique situation in medicine. We are actively inflicting harm on a healthy person to save someone else. So our ethical obligation is to minimize their morbidity to the absolute limit.
Which makes total sense.
Laparoscopic surgery offers significantly better pain control, much shorter hospital stays, and a way faster return to normal work compared to an open surgery. It's all about the recovery metrics for the donor.
So if I'm sitting there and I say laparoscopic is better because the graft survives longer, I've just completely lost points.
Precisely. You've fundamentally misunderstood the data. You have to be specific when you answer. It is better for the donor. The kidney itself doesn't really care how it gets out of the body as long as it's done quickly and safely. But the donor absolutely cares about their flank incision.
Right. Now, does that mean open surgery is totally banned? Is it malpractice to make a big incision now?
No, no, it's not banned. The guidelines explicitly say open surgery is still a valid option, especially if endoscopic expertise isn't available. And that's also a strong recommendation. You do not want a surgeon with zero laparoscopic experience trying to learn how to use the scopes on a live donor. Safety always trumps technology. If you can't do it safely via scope, you open.
What about the fancy stuff, though? Robotics?
Yeah.
Single-port surgery? The things you see at the big conferences?
Right, the flashy stuff, those are reserved for highly specialized centers only. The guidelines categorize robotic, LSS, which is laparoendoscopic single site, and notes as valid, but strictly in centers with high volume and specific expertise.
So don't offer that as your standard answer.
Definitely not. There's actually some data suggesting LASSS, where you go through the belly button, is technically way more demanding, and it has a trend toward better cosmetics, sure,
Yeah.
but it's not the universal standard yet. Oh, and you should probably mention hand-assisted laparoscopy.
Hand-assisted retroperitonioscopic, right?
Yes. Hand-assisted has a shorter op time and shorter warm ischemia time than standard pure lap, but with totally equivalent safety, so it's a very valid option.
Yeah. Okay, so for the exam, sticking to standard laparoscopy or hand-assisted is the safest bet.
Absolutely, it's the benchmark.
Now, here's a classic exam myth I really want to bust because it trips up a lot of people. The right versus left kidney debate.
Oh, this is the big one.
Right. Historically, urologists hated taking the right kidney because the vein is shorter. It was just seen as technically riskier.
And that is widely considered a myth by the current guidelines. They state very clearly, right and left nephrectomies have equivalent safety and efficacy.
So I absolutely shouldn't tell an examiner that I avoid the right kidney because it's too dangerous.
Do not say that.
Mm-hmm.
If you say that, you are showing outdated knowledge. You might say, I prefer the left because the longer vein makes the subsequent implantation easier, which is totally true.
Right.
Valid.
Right.
You cannot say the right side is unsafe for the donor to undergo. The data simply doesn't support it. You might need technical maneuvers on the back table to lengthen that short right vein, and we'll definitely get to that when we talk about implantation. But for the donor's safety, it's entirely equivalent.
Got it. Now, one last safety point on the donor surgery before we move on. I saw a very specific warning in the text about vascular control. And this feels like a massive must-know for the boards.
Yes, this is a medico-legal minefield. The FDA issued a strict contraindication against using locking clips, specifically polymer clips, like Hemolux on the main renal artery.
Just the main artery. Why? What actually happened there?
There were incidents of catastrophic failure. The clips either dislodged or they fractured completely, which led to massive bleeding and, tragically, donor death.
Wow.
You have to imagine the sheer force on that clip. The renal artery is coming right off the aorta. It is highly, highly pulsatile. If that clip slips off, the donor can bleed out into their abdomen in minutes.
That is a total nightmare scenario.
It is. Now, the guideline notes there is no evidence that staplers are necessarily safer than clips in general for other smaller vessels, but for the main renal artery, there's a specific glaring warning. Do not use locking clips there. Transfixion or staples are the only way to go.
Okay, burn that into your brain if you're listening. Locking clips on the renal artery are a no-go. That's a red flag that will fail you.
Yes.
Let's move to part 2. Organ preservation. So we've got the kidney out, now we are fighting the clock.
We are fighting ischemia. And for the exam, you have to separate this into 2 distinct battles: warm ischemia and cold ischemia.
Let's tackle warm ischemia first. This is mostly relevant for DCD donors, right? Donation after cardiac death, where the heart stops, and we basically have to get the organs out as fast as humanly possible.
Correct. In a DCD donor, the heart stops, and then there is a mandatory standoff period to confirm death, usually about 5 minutes, where you can't touch the patient, and then the team rushes in. And the guideline mentions a highly critical predictor for delayed graft function, or DAGF, in these cases.
And that is the extraction time?
Exactly.
Yeah.
The extraction time.
Define extraction time for us, just so we have the exact terminology.
It's defined as the time from the aortic cross clamp, or in DCD, the start of the incision, to the moment you're placing the kidneys on ice. Basically, how long are you fumbling around in the warm abdomen trying to cannulate and cool those organs?
And the data points they give here are staggering.
They really are. If that extraction time is under 60 minutes, the incidence of delayed graft function is about 27.8%.
Okay.
But if it drags out to 120 minutes, your DGF incidence jumps to 60%.
That is massive. So literally every single minute you waste in the abdomen actively increases the risk of that kidney not working when you plug it in.
Exactly right. Because it's a race. The kidney is sitting there at body temperature, its cellular metabolism is still running at full speed, but there's absolutely no oxygen delivery. That is the most damaging state possible for a cell. ATP is just being depleted rapidly, and damage is accumulating.
Now, once it's out and it's on ice, we shift into cold ischemia time, or CIT. The general rule of thumb is obviously keep it as short as possible. But for these exams, you need to know the specific cutoffs. The guidelines give us these ideal maximums.
Yes, let's go through the numbers. Hit me with them.
So for a DBD donor, that's brain death, your standard deceased donor, you ideally want that cold ischemia time under 18 to 21 hours. That's your window.
Right, 18 to 21.
Then for DCD cardiac death, it's much tighter, ideally under 12 hours. Because these kidneys have already taken a huge hit from that warm ischemia phase, they physically can't handle sitting in the cold as long.
Makes sense. And what about for ECD, the expanded criteria donors?
These are your older or much sicker donors. Same rule applies. Keep it under 12 to 15 hours. The lower the baseline quality of the organ, the less time you have to play with.
That makes perfect intuitive sense.
Yeah.
Now, what are we actually storing these kidneys in? I feel like there are a lot of brand names that get thrown around in this section.
It's the Coca-Cola versus Pepsi war of transplant solutions. The two heavyweights you need to know are University of Wisconsin solution, UWN-HTK, which is histidine tryptophan ketoglutarate.
And is one officially better than the other?
The guidelines say they are equally effective. That's a strong recommendation. You can confidently say you use either one.
What's the technical difference between them, though? An examiner might press you on the mechanisms.
UW is a high potassium, high viscosity solution. It's designed to simulate the intracellular environment to prevent cells from swelling. HTK, on the other hand, is low viscosity, so it flushes through the tiny microvasculature very, very easily. Some surgeons definitely prefer HTK for that initial flush because it clears the donor blood out faster, but outcome-wise, for graft survival, it's a wash.
What if I don't have those two? What if there's a supply chain issue?
Then you go straight to the backups. Celsior or Marshall's solution, also a strong recommendation. These are completely valid, guideline-approved alternatives.
And what if I'm digging around and I find a dusty old bottle of Uro solution in the back of the hospital fridge?
Throw it out immediately. The guidelines explicitly say Uro is obsolete. Do not use it.
Why is it obsolete?
It just doesn't protect against cell swelling effectively because it lacks the necessary impermanence that the newer solutions have. It's old technology.
Good to know. Don't fall for the Uro trap.
Yeah.
Now, this next topic is probably the highest yield topic in the entire preservation section right now. Machine perfusion. The ice versus machine debate.
This is huge. If you take one single thing away from the preservation section, let it be this. The guidelines have a strong recommendation to use hypothermic machine perfusion, HMP, for deceased donor kidneys.
Strong recommendation. So why is it so much better than just throwing the kidney in a standard cooler with some ice?
Because it significantly reduces delayed graft function. The machine actively pumps cold solution through the kidney, which keeps the microvasculature mechanically open. But more importantly, it's constantly flushing out the metabolic waste products and all those inflammatory cytokines that build up during ischemia.
Does it improve long-term graft survival, though, like 10 years out?
The data is actually pretty mixed on long-term survival, but for preventing that initial sleepy kidney phase, the DGF, it is undoubtedly superior. And the benefit is most pronounced in DCD kidneys and expanded criteria kidneys, but even for standard DBD kidneys, it helps enough to earn that strong recommendation.
But there's a massive technical trap here regarding how you actually set up and run the machine.
Yes, there is. You must control the machine by pressure, not by flow. It absolutely needs to be low pressure.
Why pressure?
Because high pressure completely damages the fragile endothelium of the capillaries. You want a gentle, pulsatile flow. If you crank the pressure up just to force fluid through a stiff kidney, you will destroy the very vessels you're trying to save. You are aiming for a low mean pressure, typically around 30 millimeters of mercury.
And I noticed a weak recommendation in this section that sounds almost like a paradox. The machine gives you data while it's pumping, right? It tells you the vascular resistance of the organ.
Right. It generates a resistance index, or RI.
So if the resistance is really high, implying the kidney is stiff or all clogged up, do we discard it?
No, that is the exact trap. The guidelines have a weak recommendation that says, do not discard a kidney solely based on high vascular resistance or high injury markers in the perfusate.
That seems really counterintuitive. If the machine says the resistance is bad, why wouldn't we toss it?
It is counterintuitive, but the clinical studies show these numbers have a very low predictive value for actual viability. Think about it. A kidney might have high resistance purely because of temporary vasospasm or interstitial edema from the cold.
Right.
But once it's implanted in the warm body of the recipient and reperfused with warm blood, it relaxes and works completely fine. The machine is primarily there for preservation, not for judging the organ's ultimate fate. Don't let the machine's numbers scare you out of what could be a perfectly good transplant.
That is fascinating. So the machine helps the kidney survive the transport, but it doesn't necessarily tell you the kidney is trash.
Exactly.
Speaking of judging the organ, let's transition to part 3, the biopsy debate. To transplant or not to transplant?
This is where Europe and the US diverge significantly. And since we were talking about the EAU guidelines, they strongly reflect the European skepticism towards biopsies.
Yeah, because in the US, they biopsy almost everything. And if there's too much scarring on the report, they toss the kidney. It's a huge cause of organ discard over there.
Correct. But the EAU guidelines state there is no consistent association between donor histology and post-transplant outcomes.
Really? No consistent association. So a scarred kidney on a biopsy might actually work fine.
Exactly. The recommendation is stark. Do not base acceptance decisions on histology alone. And that is a strong recommendation. They warn that heavily relying on procurement biopsies leads to massive, unnecessary discards of usable organs.
So you're throwing away a kidney that someone desperately needs.
Exactly. A kidney with some moderate glomerulosclerosis might still give a 60-year-old patient 5 or 10 great years off dialysis. You have to look at the whole picture, not just the slide.
But let's say I am going to do a biopsy. Maybe I'm in a center that mandates it by protocol, or I see a genuinely suspicious nodule I need to check.
Yeah.
How do I do it right so I don't get bad data?
You have to avoid what we call the wedge biopsy trap.
Explain the physics of that trap.
A wedge biopsy is when you just take a little V-shaped slice off the surface of the kidney with a scalpel. It's super easy. It's fast. But the problem is the subcapsular cortex, that very surface layer, naturally always has more sclerosis than the deep tissue.
Oh, because it's just the natural aging process of the organ.
Yes. So a wedge biopsy inherently makes the kidney look significantly worse than it really is globally.
It biases the sample heavily towards scarring.
Precisely. So the guideline says the superior technique is a needle core biopsy. You need to use a needle and go deep into the parenchyma.
Are there specific, measurable criteria for what constitutes a valid biopsy for the pathologist to read?
There are, and these make for fantastic multiple choice questions. The sample must be at least 5 millimeters deep, and it must contain more than 25 glomeruli.
25 glomeruli. That is a number you absolutely must memorize.
If you have fewer than 25, the guidelines say you are just looking at sampling error. You can't trust it. Also, the needle core captures the interlobular arteries, which the wedge biopsy completely misses.
And why do we care about those arteries?
Because those arteries tell you the true vascular health, the degree of arteriosclerosis. And for long-term function, that vascular health is often more important than just counting the sclerosed glomeruli.
And who should actually be reading this slide?
Ideally, an experienced renal pathologist. The guideline explicitly notes that a general on-call pathologist who's used to looking at gallbladders and appendices all night tends to grossly overestimate the degree of injury compared to a dedicated renal specialist. They see a little scar tissue, they call it severe, and boom, the kidney gets trashed.
So summarize the EAU biopsy stance for the candidates sitting in the exam room.
Don't use a biopsy to simply say no to a kidney. But if you have to do one, use a needle core, go deep, make sure you count at least 25 glomeruli, and get a dedicated specialist to read the slide.
Perfect. Clear as day. Let's move to the recipient. Part 4, implantation surgery. We are finally in the OR. The patient's on the table. First question, anesthesia and pre-op prep. Do we routinely dialyze them right before surgery to get their fluid and potassium absolutely perfect?
No. The guideline specifically says do not routinely dialyze immediately pre-op.
Why not? Wouldn't a chemically clean patient be a safer bet for anesthesia?
You would think so, but it causes huge fluid shifts. Dialysis obviously removes volume. It can lead to severe intraoperative hypotension. And think about it, what does a newly transplanted ischemic kidney need more than anything else in the world?
Perfusion pressure.
Exactly, perfusion pressure. If the patient is dry and hypotensive, the moment you take those vascular clamps off, you are basically setting yourself up for delayed graft function. You're starving the kidney.
So we'd rather manage a slightly high potassium medically with insulin and dextrose than risk them tanking their blood pressure?
Correct. And speaking of fluids, the overriding strategy during the case is target-directed intraoperative hydration. That's a strong recommendation. You want to keep that central venous pressure totally optimized. You want a full tank so the blood pushes through that new kidney.
Now, let's talk surgical anatomy. We are putting this kidney in the iliac fossa, usually extraperitoneal approach. What if we have that notoriously short right renal vein we talked about earlier from the donor?
This is exactly where the transplant surgeon earns their money. The right renal vein is naturally short. If you just try to stretch it and sew it directly to the external iliac vein, it might be under significant tension.
And tension in vascular surgery is the enemy. It causes thrombosis.
Exactly. You need length.
So how do you get it?
You have to be ready to lengthen it. The classic technique is using the IVC patch. When the donor surgeon takes the right kidney, they take a little bit of the donor's inferior vena cava along with the vein.
This is why the donor surgeon needs to know what they're doing. It's a team effort.
Very much so. But what if you don't have a patch? What if it's a live donor and you couldn't take a piece of their vena cava?
You can use a graft extension. You can harvest a piece of the recipient saphenous vein or even a piece of the gonadal vein and sew it on to make a tube. But the absolute key here is you must recognize the shortness before you start sewing the anastomosis.
Right. If you realize it halfway through your running stitch, you're in deep trouble.
You have to plan ahead. Here's a controversial one that examiners love. DVT prophylaxis. We are obviously worried about blood clots in the legs because it's pelvic surgery, but we are equally worried about catastrophic bleeding in the surgical site.
This is a really tough balancing act. Heparin definitely reduces thrombosis risk, yes, but the data shows it significantly increases major bleeding events, and it drastically increases lymph drainage issues, specifically lymphoceles.
Lymphoceles?
Yes. Heparin basically prevents the small lymphatic channels you cut from naturally clotting and sealing off, so they just keep weeping, and you get these huge fluid collections.
So what's the final verdict from the EAU?
The verdict is, do not routinely use pharmacological prophylaxis, like heparin, in low-risk living donor recipients. You should rely entirely on mechanical measures, so pneumatic compression stockings. The risk of site bleeding and lymphocele formation simply outweighs the clot benefit in low-risk ambulatory cases.
And that's a strong recommendation.
Yes, it's a very specific don't do this instruction. Obviously, caveat here, if the patient has a known history of PE or a clotting disorder, you treat them, but not routinely as a blanket policy for everyone.
Okay, we've sewn the vessels, blood is flowing, the kidney pinks up. Now we have to deal with the ureter. How are we connecting the plumbing to the bladder?
You have two main historical choices here. Extravesical, which is the Lich Gregoire technique, or intravesical, the Ledbetter-Politano.
That sounds like a tag team wrestling match. Lich Gregoire versus Ledbetter-Politano. Who wins the evidence match?
Lich Gregoire wins by a knockout. The meta-analysis strongly favors the extravesical approach.
Why is it superior?
It has significantly fewer complications overall. Specifically, you see less urine leak, less ureteric stricture, and far less hematuria.
Makes sense.
It's mechanically simpler, it's faster, and crucially, you don't have to open the bladder lumen itself. You just incise the iter detrusor muscle layers. You lay the ureter in, close the muscle over it, and you create a submucosal tunnel that acts as a natural flat valve to prevent reflux, all without the massive trauma of opening the bladder mucosa.
And regarding stents, do we put a piece of plastic in there?
Yes, prophylactic stenting is generally recommended. It prevents those major early urological complications. It's essentially cheap insurance against a leak at your anastomosis while it heals.
So extravesical Lich Gregoire with a stent is your textbook answer for the exam.
Correct.
Now, even with the absolute best technique in the world, things go wrong. Let's move to part 5, surgical complications, the nightmares that wake you up at 3 a.m.
The biggest nightmares are always vascular.
Let's start with arterial thrombosis. Rare but devastating.
Very rare. Incidence is between 0.5 to 3.5%. The diagnosis is usually incredibly sudden anuria. The urine output just stops instantly, and you get an urgent ultrasound Doppler that shows absolutely no arterial flow. If you see that, you have to move fast. Immediate surgical exploration.
Is there genuinely any hope in that scenario?
Honestly, it's profoundly low. If the kidney has been sitting there without blood for hours at body temperature, it's usually dead. You do an exploration, but it very often ends in a transplant nephrectomy. You take it out.
Right.
If you catch it in minutes, there's a glimmer of hope. You try a thrombectomy, you clear the clot, but the salvage rate is dismal. Speed is everything.
Compare that to venous thrombosis.
Venous thrombosis is much sneakier. The vein clots off, but the artery is still open and pumping high-pressure blood in. So the kidney swells up massively because blood can get in, but it simply can't get out. The pressure builds until it can literally rupture the renal capsule.
And what's the classic Doppler sign the examiner wants to hear?
This is a huge buzzword, reversed diastolic flow.
Explain the physics of that for us.
The pressure inside the swollen kidney becomes so immensely high from the venous congestion that it actually exceeds the arterial diastolic pressure of the patient. So during the diastolic phase of the heartbeat, blood physically flows backwards out of the renal artery.
Wow. That is a definitive, terrifying sign.
It is. It demands urgent exploration. You might be able to save this one if you get in, clear the venous clot, and ensure outflow, but again, it carries a very high risk of total graft loss.
What about something more chronic? Let's say it's transplant renal artery stenosis, or TRAS. The patient comes into clinic 6 months later, their blood pressure is suddenly skyrocketing on 3 meds, and their creatinine is slowly creeping up.
This is the absolute classic presentation for TRAS, refractory new-onset hypertension. You order a Doppler. The diagnostic threshold you need to memorize is a peak systolic velocity, or PSV, greater than 200 centimeters per second. Or, if they do an angio, greater than 50% stenosis visually.
So PSV over 200, what do we do? Do we operate?
No, open surgery is the absolute last resort. The hierarchy of treatment always starts with percutaneous transluminal angioplasty PTA with stenting. That's first line. You call interventional radiology, and they handle this intravascularly. You only cut if radiology completely fails or if the vascular anatomy is just too complex to stent safely.
Okay, let's pivot to urological complications. Urine leaks and lymphocytes.
Urine leaks usually happen right at the anastomosis, often because of ischemia of the very distal tip of the donor ureter. You cut away the ischemic part and redo it. But lymphocytes are interesting because they are largely preventable by the surgeon.
How do you actively prevent them?
It goes right back to the recipient surgery we were talking about. You must meticulously ligate the recipient's lymphatics around the iliac vessels. If you just quickly cauterize them with monopolar energy or leave them, they will weep lymph fluid for weeks.
And that fluid pools.
Exactly. It collects into a sac, pushes on the transplanted ureter, and causes mechanical hydronephrosis.
And if the patient gets a symptomatic one, how do we fix it?
Simple needle aspiration usually fails. It just fills right back up the next day. You need to do either sclerotherapy, which is injecting betadine or tetracycline into the sac to scar it shut, or you do a laparoscopic fenestration, where you cut a large window in the sac so it just drains freely into the peritoneum and gets absorbed.
Got it. Okay, take a deep breath. We are leaving the OR. We are entering the abstract, complex world of pharmacology. Part 6. Immunosuppression.
This is often the hardest part for surgeons to memorize because we like fixing things with our hands, not adjusting microdoses of pills. But the guidelines provide a very strict standard triple therapy regimen.
There's a strong recommendation for this standard cocktail. Let's break it down. What is it?
Component 1 is a calcineurin inhibitor, or CNI. Specifically, tacrolimus is preferred over cyclosporine.
Yep.
Component 2 is an anti-proliferative agent. That's usually mycophenolate MPA. It's proven better than the older drug, azathioprine. And component 3 is your steroids, prednisolone or methylprednisolone. Plus, on top of that maintenance triple therapy, you need an induction therapy given right around the time of surgery.
Let's break these specific drugs down. Why is tacrolimus strongly preferred over cyclosporine?
It simply has higher efficacy, it prevents acute rejection better, but, and here is the great paradox of transplantation that we always have to mention, all CNIs are inherently nephrotoxic.
They hurt the very organ they are protecting.
Exactly. They save the kidney from the immune system, but they slowly, chronically poison the kidney tubule cells over years. It's basically a deal with the devil.
And that's why we have to monitor their trough levels in the blood so obsessively in clinic.
Exactly. It has a phenomenally narrow therapeutic window. Too little drug equals rejection, too much drug equals severe toxicity and kidney failure.
Now, what about the mTOR inhibitors? I'm talking about sirolimus and everolimus. Where do they fit in? When do we actually use those?
These are niche players. You generally use them if a patient simply cannot tolerate the CNI toxicity, Or, and this is the high-yield exam point, if there is a significant malignancy risk.
Why malignancy?
Because MTR inhibitors actually have a potent anti-tumor effect. They fundamentally stop cellular proliferation. So if a transplant patient has a history of bad skin cancers or Kaposi sarcoma, switching their immunosuppression to sirolimus can actually help treat or suppress the cancer while simultaneously preventing graft rejection.
But there is a huge flashing warning label on these MTOR drugs for the immediate surgical period.
Massive warning. They severely impair wound healing. You do not ever use MTOR inhibitors immediately post-op. If you do, your incision will literally fall apart. You get massive hernias, you get fascial dehiscence, you get ureteric leaks because nothing heals.
So when do you safely start them?
Usually months later, once all surgical healing is 100% complete. Also, you don't use them if the patient has heady proteinuria like over 800 milligrams a day, because MTRs will predictably make the proteinuria much worse.
Okay, so here's a classic exam trap. A patient is 2 weeks post-transplant and has a sudden abdominal wound dehiscence. Check their drug list. If they're on sirolimus, that's your answer.
Precisely. You nailed the diagnosis.
What about the newer stuff, belatacept?
Belatacept is the great new hope for avoiding CNI nephrotoxicity entirely. It works differently. It blocks T-cell activation via the CD28 co-stimulation pathway without poisoning the kidney tubules. It preserves the glomerular filtration rate, the GFR, significantly better than tacrolimus over the long term.
Sounds perfect. Let's give it to everyone. What's the catch?
The catch is the patient's EBV status. Epstein-Barr virus.
Explain why that matters.
You can legally only use belatacept in EBV-positive patients, patients who have already had the virus. If you give it to an EBV-negative patient and they subsequently get exposed to EBV out in the world, they have an extraordinarily high risk of developing PTLD.
Post-transplant lymphoproliferative disorder.
Yes, which is basically a highly aggressive, often fatal lymphoma.
That is a very severe side effect. So belatacept equals EBV positive only.
Got it. Now finally, let's talk induction strategy. The drugs we give right at the time of the transplant to suppress the initial immune surge. We have basiliximab and we have ATG. How do we choose between them?
It's purely based on the patient's immunological risk profile. If they are low or standard risk, meaning it's their first transplant, they don't have a lot of circulating antibodies,
Yeah.
you use basiliximab.
Okay.
It's an interleukin-2 receptor antagonist. It's very gentle, very targeted, and has very few systemic side effects.
And if they are high risk?
If they are a retransplant or highly sensitized from previous blood transfusions, you use ATG, antithymocyte globulin.
How exactly does ATG work?
It's a harsh polyclonal antibody that essentially nukes the entire T-cell population. It actively depletes them from the blood. It's incredibly effective at stopping rejection, but it leaves the patient profoundly immunosuppressed. They are at very high risk of opportunistic infections like CMV and eventually malignancy. Simple enough rule for the boards. Low risk equals basiliximab, high risk equals ATG. Now, despite all this incredible pharmacology, rejection still happens. Let's move to part 7, diagnosis and treatment of rejection. A patient comes into clinic with a rising creatinine. Can I just assume it's rejection and empirically give them a bunch of steroids?
Absolutely not. That is a fail. The absolute golden rule of the guidelines is biopsy is mandatory. You cannot clinically distinguish acute rejection from acute tubular necrosis or CNI drug toxicity or a weird viral infection just by looking at the patient or their blood work. You fundamentally need tissue.
And we use the Banff criteria to score that tissue. Let's say the biopsy comes back positive. We essentially have 3 flavors of rejection. Let's go through them. Flavor 1, hyperacute rejection.
This is very rare nowadays because of modern cross-matching, but it happens literally minutes after you unclamp the vessels in the OR. It's caused by massive pre-existing antibodies, like an ABO blood type mismatch or huge HLA antibodies.
And what happens to the kidney?
The kidney immediately turns completely black and flaccid right in front of your eyes. It is game over. You have to do an immediate transplant nephrectomy. There's no saving it.
Flavor 2, T-cell mediated rejection or TCMR.
This is your most common, standard acute rejection that happens weeks or months out. It's the recipient's T cells physically invading the donor kidney tubules. The first-line treatment is a massive steroid bolus, pulse methylprednisolone for 3 days.
And if that steroid pulse completely fails?
If it's steroid resistant, or if the initial biopsy shows incredibly severe rejection, like a Banff grade 3, you bring in the heavy artillery we talked about earlier, ATG. You deplete the T cells.
Flavor 3, antibody-mediated rejection, ABMR. This one always sounds much scarier.
It is much scarier. This isn't T cells. This is caused by circulating donor-specific antibodies, or DSA, actively attacking the graft endothelium. It causes severe microvascular inflammation. Simple steroids aren't enough because steroids don't get rid of circulating antibodies. You need to physically remove those antibodies from the blood.
How do you do that?
You have to do plasma exchange, plasmapheresis, or immunoadsorption to wash the blood. Plus, you usually give high-dose IVIG intravenous immunoglobulin to try and reset the immune system and stop it from making more. It's a very difficult, very expensive multimodal treatment, and graft loss is still common.
So quick recap. T-cell rejection equals steroids. Antibody rejection equals plasma exchange.
Exactly.
We are finally in the home stretch here, part 8, long-term follow-up and special situations. You mentioned earlier that the leading cause of death in these recipients long-term isn't actually the kidney failing.
No, surprisingly it's not. The leading cause of death is cardiovascular disease. Think about it. The entire process of chronic kidney disease and dialysis puts immense stress on the vascular system. Plus, the very drugs we give them to keep the kidney alive, steroids and calcineurin inhibitors, directly cause severe hypertension, new-onset diabetes, and rampant dyslipidemia.
So we really need to be treating the whole patient, not just their creatinine level.
Exactly right. Strict, aggressive control of blood pressure, lipids, and glucose is just as important as the anti-rejection meds. Because if the patient dies of a massive myocardial infarction at age 55 with a perfectly functioning transplanted kidney, we have ultimately failed that patient.
What about cancer risk? That's always a big topic.
Malignancy is the other massive long-term risk because of the chronic immunosuppression, specifically skin cancers and lymphomas. But examiners love to ask a specific question regarding pre-transplant cancer. Like, if a patient on dialysis has a history of prostate cancer or maybe a small renal cell carcinoma, can they ever get a transplant? Or are they banned?
Yes, they absolutely can. The EAU guideline says they can be listed for a transplant if they have appropriately treated low-stage or low-grade disease, and they can be listed without significant delay. You don't necessarily need to make a guy with a Gleason 6 prostate cancer wait 5 years on dialysis just to prove he's cured. You can transplant them once they're definitively treated.
And finally, going back to CNI toxicity management, if you do a protocol biopsy at 1 year and the histology comes back showing striped fibrosis, which is the absolute classic hallmark of chronic CNI damage, what do we do?
You have to back off the drug that's actively causing the damage. The guidelines say you must consider CNI dose reduction or total withdrawal. You might switch them over to mycophenolate for protection, or if their protein is low enough, you switch them to an M2R inhibitor like we discussed. But you absolutely have to stop the active poisoning to save whatever nephrons are left.
Wow. Okay. This has been an absolute whirlwind tour of a massive document. Let's try to bring it all home. If you had to summarize the absolute must-knows for the board exam, the strong recommendations that a candidate simply cannot afford to miss under any circumstances, what are they?
All right, get your pens ready. Number 1, living donor surgery. You must do it laparoscopic. It's entirely for the donor's benefit and recovery.
Got it.
Number 2, deceased donor preservation. Hypothermic machine perfusion actively reduces delayed graft function. You must recommend using it.
Number 3.
Number 3, do not discard donor kidneys based on a procurement biopsy alone. It's highly unreliable and leads to waste.
4.
Number 4, for standard maintenance immunosuppression, tacrolimus is unequivocally superior to cyclosporine.
And 5.
And number 5, if you ever suspect acute rejection clinically, you must biopsy the graft. No guessing. No empirical steroid blasts without tissue proof.
Crystal clear. And I want to leave our listeners, as we wrap up, with one final, slightly provocative thought straight from the implications of these guidelines.
Let's hear it.
We have all this incredibly high-tech pharmacology, right? We have continuous machine perfusion, we have advanced genomic and HLA matching, and yet the ultimate decision to accept or reject a marginal kidney very often comes down to an exhausted pathologist looking at a rushed frozen section at 3 in the morning, a practice which the guidelines explicitly tell us is highly unreliable.
It really is the great paradox of our field right now. We are incredibly precise and scientific in our medical treatments, but we are still vastly subjective and archaic in our initial selection of the organs. The future absolutely has to be in better dynamic assessment, like letting the organ prove its metabolic function while pumping on the machine, rather than just looking at a static slice of tissue under a microscope.
It's definitely something to chew on as the field evolves. To all the urology trainees and fellows out there listening, good luck. Go crush that exam. You know the EAU guidelines inside and out now. Thank you for walking us through this incredible boot camp.
It was my absolute pleasure.
See you next time on The Deep Dive.